kind of sit up high up here. And I said, go down to Phoenicia. And then Dias. As I recall, the public sits way down below.
Yeah. It's a little, maybe a little bit higher, not a lot. There was talk of changing that.
It kind of feels almost like a monarchy or something. It's very interesting. I went there once or twice. I had to go down for, I think it was something that Elizabeth was doing at the time. It was always...
Well, it was a school auditorium.
Yeah.
That was their stage. So that you're already on the stage, and then they build a dais above it. So
interesting.
How was your Christmas?
It was not bad. Didn't go anywhere.
Good.
Stayed in Vacaville, where I live, and family and stuff, so didn't do any travel. We used to travel all the time. I mean, we'd have to, my wife's family's down in Southern California, but they've pretty much either relocated or not alive anymore, so, don't go down there anymore, which is nice, because I remember the last few times we did it, I remember one time we went down there Thanksgiving, and I-5 was just jammed up all the way through Bakersfield. I mean, it was just, I don't want to do this anymore.
Yeah. We do off schedule, so I'll make my brother a couple weeks beforehand. And he's only in Lincoln, so it's not too bad. But same thing, nobody wants to sit in traffic on Christmas and Thanksgiving. Stay home.
Oh, yeah, and going towards Sacramento these days is a crapshoot, right? I mean,
Thursday afternoon, you're screwed. Fridays, you're screwed. One little accident. Yeah.
that 50-80 convergence is just a nightmare, Do we have a quorum? I'm looking here and I'm going, huh?
He slept since then. That's what I usually do.
what do we have total? Is there 7 of us? So 4, we need 4?
I think we need 4, yeah.
Good morning.
Good morning. Good morning.
Good morning.
What do we need 4 or 5 to 4.
We were hoping for 5 because we never like to even. But he had called out sick earlier, and we still need to replace Greg. We need to get that up and show by hopefully next meeting.
Well, the city managers have a meeting, I think, next week, is it? I think
I
it's
thought
not.
they already picked someone.
Well, I thought they picked the
Vista one.
Rio Vista city manager, but
Nothing's been brought up, so maybe you can bring that up in the meeting that they need to reach out to us, or I can maybe truck a letter for you, Bill, to bring to that meeting.
yeah, let me. I'm going to text Gasaway right now.
You should just show up at the meeting, ask for 3 minutes, and say, "Hey, I'm just looking for a name." That's not a bad thing. They won't kill you.
I'm going to text Gasaway right now.
You maybe.
I showed up at one meeting that I thought Robin Reigns and I showed up and we haven't been invited to this, but we're going to probably get it was the fire chiefs and police chiefs meeting.
Oh yeah.
Let's see if he responds. See if he gets back to. I thought they'd already done it actually.
I was told they did, but it sounds like maybe they didn't follow through the next step of the
It's like saying, "Hey, here's your new person on the list." Yep, he said it's Christina. So they did appoint the city manager from Rio Vista.
Oh, they did?
Yeah,
Okay.
I just got a text from Gasaway.
Okay.
Of course, she probably doesn't know.
So is there something formal that they need to do? Does she just show up to a meeting, or is there something formal that the city manager needs to do, or she needs to do to,
Probably just recognize it at the next meeting.
so she can just get to?
Yeah, I just think there hasn't been that next connection that we needed.
Right.
I think they did this last month.
Oh, yeah, I asked and was told that it hadn't happened yet.
Yeah.
Asked a couple times actually, so I guess so. Yeah, and I think at the next meeting, obviously, we'll share all the information so that, who is it? I'm sorry.
Christina from city manager from Rio Vista, the new one.
So I'll let her know about the meeting, send everything to her. and then
She was new.
At the meeting, do something to acknowledge that she's new.
She's new, and I think they just said, "Hey, you're going to go do this." She's actually very nice. I actually enjoy working with her. So
Oh, okay, we got 4.
I think we got the 4, so we can. Hey Ben. Oops. I didn't. How come that's? All right, we'll go ahead and get started. We now have a quorum. Good morning, everybody. Happy New Year. Nice day today. Actually get some sun, so it's kind of nice change from what we've had recently. Let's go ahead and do roll call.
Bill Umlin,
Here.
John Jansen, Joshua Chadwick,
Here.
Caesar Javaharian,
Here.
Thea Gibney, David Piscinati,
Okay, thank you. We have a quorum, barely. Items from the public. So this is a chance for folks from the public to make any comments they want on items that aren't on the agenda today. So if anybody has anything they want to bring forward, do it now. I see everybody staying in their seats, so let's keep going. We'll go to approval of the minutes from October 12th. Has everybody had a chance to review the minutes? Any comments on the minutes? Anyone want to make a motion on the minutes?
One change
Oh, okay.
to the agenda, it's resolution. It's switching it from 22-001 to 24-001. So on regular calendar B, we'll be switching from 22-001 to 24-001.
Okay, so that's a minor change to the agenda item. Okay. But let's go back to approval of the minutes.
I'll make a motion to approve.
Second.
All in favor?
Aye.
Aye. All right, we have passed minutes. And then on the approval agenda, Ben, that was the main change?
Yes.
All right, so,
Yeah, it was just a number.
okay. A motion on the agenda.
Can
To
I
approve.
can I ask a question on that? And maybe this is for the attorney. Is there something that says how far in advance the packet gets published? Is there 24 hours, or is there any rule on that?
Yeah,
It's been a little difficult with the short staff, but we usually shoot to get that, like the last one that we did with the healthcare strategist, at least 10 days prior. That was my goal, but we just ran into some obstacles. So I do try to get it out faster.
Okay. I just feel like, I remember last year when we did the budget, it was a similar thing where we got it, and like I got this at 10:30 yesterday morning and had a full day of meetings all day, and like I don't feel like I had a time to even really look at it until an hour this morning. So it's just a note that it's really tough to do that.
Is that something that we can maybe set? Okay. I mean, that if we want to set a time, like a day, if we want to go back to the 10, like we did last time, Bill?
Yeah, I mean, probably the best, I think, like, for example, if we can get it out on the Friday before, the week before, is not a bad way to go. It gives folks the weekend and such
Okay.
to look at it. So I think that would be my suggestion.
Friday prior.
Yeah.
Okay.
That makes sense.
With the agenda, okay.
Okay, so we do need to approve the agenda. Do we have a motion?
Motion to approve.
I'll second.
All in favor?
Aye.
Aye. Okay. Then we'll go on to reports, and we'll start out with the SEMSC Medical Director's report.
Good morning, everyone. This will be pretty short. So as all of you know, we're really working on revamping a lot of our protocols, which are quite outdated, and also combining our BLS and ALS protocols into one document to represent the appropriate continuum of care between first responders and transport providers. So this past quarter, we worked on three main protocols. That was one which is Protocol C3, which is now a combined protocol for cardiac arrest, which essentially replaces several protocols, including BLS C3, ALS C3, ALS C4, and ALS C12, just to make it much more easy and straightforward to follow in the field, including an old cardiac arrest memo, which has been revised. So that's currently out for comment, and the end date, I believe, is tomorrow, if I'm not mistaken, on January 12th. So that should be finalized very soon. We additionally have a new protocol, which is titled M11 on sepsis, essentially intended to initiate early fluid resuscitation in the field for suspected sepsis, which is also out for comment until January 12th. And then we have a special protocol, which is S13, which is essentially the procedures on creating an epinephrine drip that we're now utilizing in the field to allow for paramedics to treat hypotension that's unresponsive to fluid resuscitation with epinephrine as they would in the hospital setting. And so that's also out for comment until January 12th. So ideally, those will be completed and enacted very soon. Up next, for the next quarter, we're going to look at our respiratory protocols, which is about 7 protocols or so. We're hoping to follow the same process to combine and simplify those as much as possible. On EMT discipline, we had mentioned this last time that there was a pending case that was essentially we were waiting for a judicial decision on for an EMT's essentially a DUI which occurred with an EMT. That has resulted in a criminal conviction, and so essentially we're going through the process of revoking that EMT's license right now. So it's technically still pending on our side, but it will be completed this next quarter. And that concludes my report. Happy to take any questions.
Okay. Seeing no
Thank you.
questions, we'll go on to the EMS Administrator's report.
All right. Thank you, Bill. Good morning, board members. As we close a remarkable year, 2023, I want to reflect on our great EMS team and all the achievements that we are able to achieve in 2023. I look forward to seeing the challenges and the future achievements that my great EMS team and the county do in this coming year, 2024. With that, I'm going to go straight to the system performance. This is for year 2023. It'll be for the first quarter. We'll have our exclusive operating area provider, Medic Ambulance. First quarter is going to be at 98%, overall 98.7%. Now to the PPP providers. Starting off with Venetia at 94.6%, overall 95.2% on responses. Dixon, 94.9, overall 97.4. Fairfield, 93.8, with an overall of 93.9. Vallejo, I know it's blurry. I don't know if it came out blurry on everybody's, but it's 93.8 is the first quarter, and overall 93.9. Sassoon, this will be the first time of reporting for the city of Sassoon after them joining the PPP, and their numbers in the first quarter will be 95.7 and 95.9 in overall response time. Going up to system updates, I'm very happy and pleased to announce that the city of Fairfield went live with their emergency medical dispatch yesterday as of, I think it was a little after 8 o'clock. Scott Wagnus and I were in the room. We listened to the first call. One was a typical fall victim that they EMD'd, processed it. Everything went smooth. The second one came out. It was a infant with choking, and it was rewarding to see how quick and the information that the dispatcher had to help that caller. I mean, it was substantial. I mean, I'm really happy with how the system rolled out. It took us a little bit longer, and I know that we still have 3 other cities in our county to work on EMD, but just seeing one come online, we're going to be able to take all the data, the overtime, the staffing, whatever everything was needed to get them online and get that program going, to be able to bring that to the remaining other 3 PSAPs. So I know that'll be further in Scott's report, but just wanted to give a system update on that. And also, we executed the contract with Healthcare Strategists, and they'll be working with us the next couple weeks on stakeholder and starting their review for the RFP process. And that's it for the Administrator.
All right. Any questions for Ben? Okay.
Actually, what is the difference between first quarter and overall?
I'll actually reflect that to my data, Adeline. Thank you, Alan.
Okay. Dr. Manish, did you have a report as well? No. Okay. Then we will go on to the medic ambulance operators reports.
Good morning, everybody. My name is Sandra Whaley. I'm the VP of Communications for Medic Ambulance. And we just wanted to go through a couple things. We had a record year this last year, 2023, for Medic Ambulance. We had our most transports and also over 90,000 requests for service for 2023. So record year. We maintained our relationships with our pre-hospital partners as well as our hospital partners and also county partners. So we're really proud of that relationship, as well as continuing our relationships within our communities because that is important to us. So we continue to expand our relationship with our community-based organizations and nonprofits, and we continue to do that this current year. Regarding fleet, we added 6 ambulances to the fleet in 2023, as well as 10 Power Pro 2 gurneys. This is the part of the toy section. So one of the other things we did add in our fleet, we took delivery of an ATV ambulance, which is fully enclosed, that we just received. And it does off-road and all that fun stuff. So once that is done and ready to go, we'll invite you guys all to come and see it, because it's a really cool thing to have. In addition to those 6 ambulances we added in 23, we're adding 6 more ambulances to the fleet in Solano for 2024. Jimmy just finished his 2-year stint as president of the California Ambulance Association, and then in turn was elected to the board of directors for the American Ambulance Association. And he is going to be representing District 5, which includes California. So he just started that after his CAA stint. One thing we also would like to do for sure is to thank our employees. We're very proud of all the work they did within our community and for our patients, and we couldn't be here and do this without them. So we're very proud of them and want to thank them officially. Also, we did provide scholarships to 10 EMTs to go to paramedic school in this last year, and we'll continue to do that as well. The 10 paramedics or EMTs some are in the field already, some are still in school, but that is one of the programs that we put in place to, again, retain employees and get good people here in Solano County. That in addition to our retention bonus, which we started 2 years ago now, and our pay and benefits, we're proud to say that we do have great staffing and continue to maintain great staffing and great employees, which other counties are kind of struggling in. So we're really proud of our programs that are keeping people here in Solano County and helping our people. Let's see, 2024 looks to be a great year. First and foremost, Medic is celebrating our 45th anniversary. June 1st will be Medic's 45th anniversary, and we're very proud of that. Another thing that is starting in 2024, actually next week, we are going to be starting our contract in Sonoma County in conjunction with the Sonoma County Fire District. We're going to be adding on 31 ambulances and 141 employees, and it's the largest expansion in our company history, so we're really excited about that. In addition to that expansion comes an expansion to our disaster response capabilities. So in Solano County, we have our AMBU bus, we have our specialty ops vehicle, and we also have our mobile command. Those 3 vehicles we are matching in Sonoma. So we will have those same 3 resources in Sonoma as well as Solano. So we are going to be expanding our disaster relief capabilities. So again, something that we're really proud of. And I believe that is the last that I have, unless you guys have any questions for me.
Yep. All right. Any questions?
All
Thank
right,
you.
Thank you so much.
All right. We'll go on then to the EMS quarterly activity reports.
Good morning. My name is Adeline Ansari, Health Education Specialist with Solano EMS, and today I, along with my colleague Scott Wagner, will be presenting on EMS Quarterly Activity Report for the reporting period of July 1st through September 30th. First, we are looking at the general overview of today's presentation. We will start with EMS applications, and then we will present on general EMS data, followed by specialty care programs, and we will end our presentation with new and ongoing projects. As for EMT certifications, for this reporting period, we had 78 EMTs, which 34 initials and 44 renewals. We had 32 paramedics, which we had 11 initial and 21 renewals. And we had mobile intensive care nurse, which also known as MICNs. We had 1 initial and 1 renewal. As for general EMS data, again for reporting period of July 1st through September 30th, first we are looking at 911 call volume. In this slide, you can see the bar in purple that shows the total 911 requests we received. The bar graph in blue shows how many patient contacts we had, and the bar graph in green shows that out of those patient contacts we had, how many we actually transported from the scene to the hospital. And you can see on average, we transported 94% of the patient that we made the patient contact with from the scene to the hospital. Next, we're looking at the city of incidence, again for reporting period of July through September. And this data only includes those patients that were transported from the scene to the Solano receiving facilities. So this slide does not include any transfers out we had to the other counties. As you can see, the graph in blue shows the actual 911 call requests each city had. And just to have a fair comparison among all of our cities, because our cities have different population size, we calculated incidence rate per 100,000 population. And as you can see, Rio Vista has the highest 911 request. There are many different reasons behind why Rio Vista has higher 911 requests, but one of the reasons it could be that when you are looking at the persons 65 years and over, Rio Vista has the highest percentages for that. Next, we're looking at 2 sets of data here. The graph to the left, it shows the response priority. It shows that how many patients were transported from the dispatch. We responded from a dispatch to the scene as code 3, which is light and siren, so that's 93% of the time. We responded from dispatch to the scene using code 3, and we had 7% code 2, which is no light and sirens. On the right, you can see the transport priority. So it shows that from the scene to the hospital, we transported 7% of our patients under code 3 and 93% under code 2. Next, we're looking at the level of treatment received. So here you can see the trend analysis for over 1 year divided by each quarter, showing while we were transporting patients from the scene to the hospital, what type of treatment we provided to them, if it was ALS or BLS. As you can see, around 65% of the patients, they received ALS treatments on average, and then 35% received the BLS treatment. Next, we're looking at the ambulance patient offload time, also known as APOD. So here we have a dotted line in red that shows a 20 minutes mark, which is our benchmark for APOD in Solano County. And then we had also the dotted line in green, that's the future potential benchmark for APOD for California. As you can see, on average, for the last 12 months, our APOD was standing in around 21 to 22 minutes. I know it's a little over our benchmark in Solano County, but it's definitely way below that 30 minutes mark for the future potential California APOD benchmark. Next, we're looking at the specialty care programs, and here's the list of our designated hospitals for our 4 specialty care programs, and the list of the hospitals and designated hospital has not changed since last we reported. Next, we are looking at quality improvements. As it was mentioned before, on quarterly basis, we meet with our pre-hospital providers and hospital providers to go over our specialty care data to make sure that the data collection and the data analysis process is going smooth. And then also that opens up the door for us to change any protocols that we need to change or update any policy that we want to change. And actually this afternoon, our team is going to present on STEMI and stroke. Just to give you guys an overview what we're going to present at today's EMS quarterly meeting, I will go over the few slides of the stroke and STEMI presentations. So starting from the stroke for overall system performance, we have a diagnosis slide. It shows that out of all the patients that experienced stroke in our county, on average, 80% of the patients had an ischemic stroke, and around 20% had a hemorrhagic stroke. So here we're looking at the time to IV thrombolytic therapy, and which we also call it door to needle time. So door meaning the patient getting to the ED door, and a needle time means the time that they receive the treatment. As you can see in the chart below, there is 3 different benchmarks by American Heart Association, which we also call it AHA. So in green, you see that the AHA benchmark is that at least 50% of the patients receive the treatment within 30 minutes. And you can see we are a little below that 50% benchmark. In yellow, we see that the AHA benchmark suggests that at least 75% of the patients to receive the treatment within 45 minutes. And as you can see, the line graph in yellow, we are a little below that benchmark. And the last benchmark is in blue. The AHA suggests that at least 85% of the patients receive the treatment within 60 minutes. And you can see we also a little below that benchmark. So we are aware of this, and we are working with our providers to make sure that we improve in this area. Next, we're looking at the last known well time to IV thrombolytics. Here we have one benchmark for 2 sets of data. So AHA suggests at least 85% of the patients received treatment within 3 hours if they arrive by 2 hours, and or receive the treatment within 4.5 hours if they arrive by 3.5 hours of their last known well time. As you can see, we are way above our benchmark, which is good. Next, we're looking at the stroke education. AHA suggests that at least 75% of the patients are stroke patients to receive education while they're in the hospital. As you can see, we are doing really great in that area. Next, we're looking at our STEMI data for reporting period of April through September. Here we have a demographic slide. It shows that for this reporting period, we had 81 confirmed STEMI cases. which looking at those 81 confirmed STEMI cases, meaning those patients, they needed actually intervention to remove the blockage. That's how we call those patients as confirmed STEMI cases. Out of those patients, 74% of them were male and 26% were female. And you can see the breakdown of the race and ethnicity, and then also patient age breakdown. As you can see, most of the patients there were white in an age range of 70 to 79. Next, we're looking at the median first medical contact times. So on the left, you can see the graph that shows the first medical contact to balloon time, meaning the time that the patient received the treatment. And all of these numbers are in minutes. There's an AHA benchmark for that. So AHA suggests that at least our patient needs to receive the treatment within 90 minutes of their first medical contact As you can see, we are a little below that benchmark, which still is good. Also, there's something else that we track that there's no AHA suggestion benchmark for it. We calculating or kind of monitoring our first medical contact to EMS notifications, to meaning that how many minutes it takes a paramedic to notify a hospital that they have a STEMI patient. So there is no AHA benchmark. We want to track that to make sure to see how many minutes paramedics they spend on the scene before notifying the hospitals that they have a STEMI patient. And we are standing on average around 18 minutes now. Next, we're looking at the STEMI alert status. For this reporting period, we had 155 potential STEMI cases, which 108 was brought into the hospital by EMS. We had 19 walk-ins, and we had 28 interfacility transfers. Out of those 108 that was brought in by EMS, we had 57 patients that they needed to have a cardiac activation, meaning to need a treatment, and 51 patients did not any cardiac laboratory activation. And I'm pleased to announce that we had a 0 missed STEMI patients that was missed by our paramedics. So we had 0 that was missed by our paramedics, so we're very proud of that. Next, we're looking at a monthly median door-to-balloon time. Again, these numbers are in minutes, and you can see the breakdown for each month. There's the AHA suggested guidelines that is standing 90 minutes, meaning from the time that the patient gets to the hospital, they need to receive the treatment at least within 90 minutes. As you can see, we are way below that suggested benchmark, which shows that we're doing great. And we have a monthly median report for door-to-door to balloon time. So these are for the interfacility transfer patients. So patients that went to the non-STEMI hospitals and they had to go to the STEMI hospitals and then receive the treatment. And the AHA suggests that those patients, they need to receive the treatment at least within 120 minutes. As you can see, we are doing really great in that area as well. So that concludes my part of the presentation. I will turn over the presentation to my colleague Scott Wagner to go over the new and ongoing projects.
Hello, everybody. My name is Scott Wagner. I'm EMS coordinator for Solano County EMS Agency. I wanted to give you a brief overview of some of our projects that we're working on at the agency and explain some of the information behind it. So first off, we can start with BFAST stroke awareness outreach. Recently, we've been working with the Solano County Long-Term Care Facility Coordinator to distribute materials throughout the long-term care facilities to the providers and staff and also family members and patients. We've been ordering additional printed materials that includes magnets, brochures, pocket guides, and informational paper informational pamphlets that can help explain this BFAST stroke scale. And then we're planning our future distribution of materials throughout the community to kind of best figure out where we're going to place these materials to get them spread out through the community to increase stroke symptom awareness. Next is EMD. I'm proud to announce that we were at the launch of EMD in Fairfield yesterday. Everything went well, really well, and we have no operational issues or delays currently. As Administrator Ben Gammon explained, we were able to watch the first call come in and then subsequent calls after that. The dispatch center did a really good job adapting to the new program, and pretty seamless transition. And like Ben said, we were able to watch them dispatch units for pediatric choking. And previously, they may not have been able to provide as much detail or guidance on what to do or what not to do in certain situations. And this had a good outcome that we were able to kind of watch happen minute by minute, and it was really nice to see the EMD program working with that. Areas of Solano County that currently do have EMD coverage are Fairfield, Vacaville, Dixon, Rio Vista, Sheriff's Office Dispatch, and Medic Ambulance Dispatch. We're going to be working with the other PSAPs in the near future, try to get some cost assessments of what the transition process took at the areas that we're able to transition, and then see what we can do on the agency side to help facilitate the EMD throughout the county, because it's proven to be a very beneficial resource for everywhere that has it. For our BLS and ALS protocols, we're going to continue to combine our BLS and ALS protocols into a single protocol. This just streamlines the process for the care providers to reference and kind of gets rid of some doubles of one protocol going with another protocol when you can just put it all into one and make it kind of streamlined. We've also been comparing each of our protocols to the current California standard of care and making adjustments as needed, because there's always ongoing research and development that kind of shows where we should be improving our protocols or making changes or adjustments to our medication dosing. We're also creating new protocols based on provider requests and internal discussions. We've been able to get some valuable input from our ambulance providers and our fire departments and other healthcare providers at hospitals to kind of direct our protocol implementation and where we should look at adding new protocols that may be beneficial to our population. Like we said earlier, our current protocols that are out for public comment are the C3 cardiac arrest, M10 sepsis, and S13 epinephrine drip. Two of those protocols, I'd like to say, were recommended from field providers, and it was nice to be able to implement those. Upcoming development is going to be focused pretty heavily on IGEL-related protocols and training materials. There's a significant packet of information that we need to put together before we can think about that transition. And that's going to be our new upcoming airway device, and then some of the remaining cardiac protocols and respiratory protocols that are going to be associated with airway management. Now on to the IGEL. In 2024, Solano County will be transitioning to IGEL Rescue Airway Device. This is a device that's a backup for oral intubation for airway management patients or patients that are difficult to intubate that you cannot establish that advanced airway. You'd utilize this device in place of that, and other situations where you have limited patient access or other complicating factors. Most of other counties in California have switched to the IGEL as their backup airway device, and we have been going through the process of vetting that device, looking at the research, having the company's representative come in and teach all of our field providers an instructional class and informational class so that we can have a good idea if this device is right for our system. Right now, we do not have an advanced airway for pediatric use in Solano County. Some other counties do have IGEL that they can use for those situations. And I'm a member of the EMS for Children Technical Advisory Committee, and I've discussed with the committee what the recommendations is for pediatric airway management, and they recommend to utilize the IGEL device for pediatric airway management, especially in out-of-hospital cardiac arrest. So we're going to be doing all the legwork and research to get that put into place in the upcoming year. This is the device itself. It's a very simple device. It has a non-inflatable cuff at the base, a 15-millimeter connector at the top that connects to all of our current airway management BVMs and ventilatory devices. There's adult sizes and pediatric sizes, and I've utilized this device myself in the field, and it's a very simple device to use. The King tube on the left side there is our current rescue airway. It's been the rescue airway in California for many years. It's been widely accepted and used throughout the state and throughout the country. It does use an inflatable balloon as a sealing device for the cuff at the bottom, And there are some complications that research has shown can develop after insertion with this device. So that's kind of helped our decision to transition to a new device. iGel is going to be our new rescue airway. It's been recently approved throughout California in the standard scope of practice for paramedics. There's no inflatable balloon, it has simplified insertion. There's tactile feedback when you insert it. And this design has fewer potential complications after insertion. So that is my presentation in whole. If you guys have any questions, I'd be happy to answer them, or anything about the other parts of the presentation. And thank you for your time.
I do have a question, if you don't mind. It might be overall. So the EMD program that started in Fairfield and is used in other departments is primarily for just providing care guidelines to civilians over the phone, correct?
Pre-arrival instructions.
Pre-arrival, right.
Yeah,
Okay.
and with life-saving measures.
And in that system, is it designed to eventually go to priority dispatch?
Yes.
Because if you look at the slide, 93 and 7 and 7 and 93, that doesn't make any sense whatsoever, right? That our system is completely flip-flopped and backwards. So if that is part of the system, what is the time frame for implementing that part or encouraging PSAPs to move towards that?
I think we have a great opportunity with the new contract coming with the exclusive operating area to put that in the contract and to visit that. I know that cities like Vacaville have had it for over a decade, maybe setting that up with a trial before we go live with the whole county. But we really need to work on those 3 other PSAPs before we implement, pretty much a tiered response in the county to make sure that we can do the same service throughout the county. So timeline, I'd love to give you a timeline. I think once we get them all live, I think it would be a little bit more achievable to give you a timeline.
Okay. All right.
But it's definitely something with all the data that my team has been collecting, the protocols that we're adjusting, streamlining them from BLS to ALS. This is all the stepping stones to working in that direction.
And the biggest hang-up with the other PSAPs is dollars, obviously?
It comes down to staffing, it comes down to overtime, logistics of the training, and the 3 other PSAPs would have to deal with the same that the Solano County Sheriff had to deal with labor disputes, because it's not in their job description as dispatchers. Fairfield was unique and had that in their description already, so it was a streamline. They could assign it to their dispatchers without any labor issues.
Okay.
So, a couple challenges, but we'll be, working towards that.
Thank you.
Yeah, I have a couple questions way back to slide like 5 and 6. Or maybe go to 6. On that one, so it's talking about, well, 2 things. One is the number of patients. It's only calculating the ones that go to Solano County hospitals.
Yes.
Why is that? Like, doesn't a patient care report go to the county even if it goes out of county, or is that not the case?
Yep, we do have that, but for the purpose of just looking at our cities in our county, we decided just to look at the ones that went to the Solano County receiving facilities.
Because you're losing a lot of data from,
Right.
in Benicia, a lot of patients go to Contra Costa.
Rio
In Dixon,
Vista.
they go to Davis.
Yes.
In Rio, they're going, across. So you're losing a lot of data by
Yes.
only calculating that.
Yes, so interested to include the out-of-county transports too
Yeah.
for the next time? 2 tables? Perfect, yes.
And then the other question would be, where you have on this slide all of the cities listed, where do all of the county patients, their unincorporated county, where is that data?
Are you talking about transport in the district?
Well, like if a patient is in Montezuma's area or Sassoon District or...
So this would be the transport agent, so it should be coming up in the city of region, is that correct? I believe, like in Montezuma, it would be the Rio Vista, so
Yes.
we'd be capturing that from medic transportation? I'm trying to see where,
Yeah,
There's a lot of transports that originate outside of the cities.
yeah, and it
Oh.
just,
yeah. that's not included in this either. It is assigned to the nearest city if it's outside of our county. And then that's the, let's say, AMR, right? They transport from, I don't know, Contra Costa or was Oakland?
No, I think what he's talking about is Montezuma, Suisun District, Vacaville District. Is that correct?
Yeah.
You're talking about the cities, the non-PPP cities.
If you look at a map of the county, there's city limits that are covered by the cities, and then there's a huge area of unincorporated, not the population isn't huge, but the area is huge of unincorporated county. And those are covered by districts and sometimes cities, and I'm just curious if that data is collected in this slide.
And I had a comment from Medic who said it is based.
So when we get the call, it's based on the city agenda, it's not by the jurisdiction. So if it's in the city of Vacaville zip code, it would be the city of Vacaville zip code. If it's the city of Fairfield zip code, it would be the city of Fairfield zip code. That's how it just shows up in our system.
Okay.
So it should be represented.
All right, that was it. Thank you.
That's it? Well, thank you for the great suggestions.
Okay, do we have more reports, or is that it? Okay. All right, then we will go on then to items from the public again. And this is basically for folks in the public who want to speak on our regular calendar items today. And we do have 4 of them, so we have several items that we'll be going through. So is there anybody from the public that wants to speak on any of the regular calendar items? Okay, I'm seeing nobody, then we'll go ahead and start with the regular calendar. And this is the selection of the vice chair for 2024. Do we have any motions on, do you have something on that, Ben? No. Well, the new city manager from Rio Vista was appointed. I don't think she knew she was appointed, so we could really surprise her.
Currently, it's John, right?
Yes.
Are you willing to continue? I'll nominate him.
So much extra work, I'll second this.
All right. I think we have a motion and a second. So all in favor?
Aye.
Aye. Then let's go on to review and consider approval of the annual SEMSC budget, revenue allocation plan for 2024-2025, and adoption of a resolution reflective of that. So go ahead and turn it over to Ben.
Yeah, so the expenses and the revenue is provided here in the packet. It's definitely reflecting that, we're looking forward to hopefully an evaluation and a survey of cost for our department in the next contract. Our franchise fee was set back in 2010, so there's been many adjustments, many increases in charges that we're kind of trying to budget. We were able, it's another regular calendar item, I believe it's on C, for the increase of the franchise fee. We were able to work with our partners, Medic Ambulance, on increasing the franchise fee as long as the board votes on that. And the next agenda item for the additional $50,000 that will start in April 2024. That will help us cover our costs and stay in the positive. The one charge that's not on there would be the RFP process with healthcare strategists. So when we see expenses of 307, 639, we would be adding, I believe, it's 178, I don't have the exact, but it would be 178 for the healthcare strategist for the RFP process. But this does not include the additional $50,000 on the franchise fee.
Is that it, Ben?
Yeah.
Okay. All right. So any questions, comments on the proposed budget?
A few things. One is, can we make this print bigger next time, please?
Yes.
I mean, I really having a hard, and I had my eyes checked yesterday. I'm doing pretty good with my glasses, so no changes, but I just can't see it.
Yeah, well,
and then I would like to echo getting the information earlier, especially at looking at a budget and
Okay.
and approving it, that would be a good thing. On the EMS coordinator, there's like an increase of 75,000 or 65,000 or so. What's that for, from the 23-24 budget to the 24-25?
It's because we filled the position. We had one.
So we have two now?
We have two, yes.
We have two, that's,
Yeah.
okay.
And also the first year of Bela.
Okay. Perfect. So what would be helpful for me is when we do the budget, is that there's explanations and or a presentation just to review the budget very quickly and say, hey, look, we have an increase. You'll see one here of 67,000. This is from exactly what you just said, right? And here's the overall. And are we, where are we with our revenues and our deficits, and how does that play out? So that would be helpful, at least for me, to hear some of the backstories, on the thing that's a grand or 3,000 or 4,000, I'm maybe not worried about that, but when you have larger numbers to approve, it'd be nice to get the backstories on that.
So any major changes, more of a focus. Okay.
I'm good, thanks.
I just have a question. So my original thought was I was going to abstain on this just because I did not have time to read it, but the question would be with our core, with only 4, would that make it so it wouldn't pass? I have to, okay. I was planning on abstaining from this vote just because it doesn't feel responsible to approve a budget without having a chance to review it. And literally getting it yesterday, like I said, I didn't have time to look at it, but I don't want to do that if we only have 4 people and need 4 for a quorum, so therefore I'm going to still vote.
Is the time frame we have to do it now, or do we have an additional meeting that it can be done at?
We schedule it for January, so if there ever has to be brought back up in April, we can do that, and we can always ask for a special meeting if needed. So yes, we do have time, because it's not on the fiscal year. We usually approve January. I think the latest was April.
I think the bylaws say January, but we could do a special meeting in the very near future to handle that if necessary, but I would recommend doing that sooner than later.
Yeah, my preference would be we'd do it in February if we're going to do that. So if that's you've got the information here. Okay. And I do have a question myself about the historical reserve balances and what you guys are projecting going forward. You have that in attachment C.
Mm-hmm.
See that it jumps around quite a bit from year to year. So. I think that would be helpful. Thank you.
Yeah. So the money from the reserve, not including the 50,000 and not including the possible COVID, is you're pulling 329 out of, is the balance currently 461? Oh, yeah, I see. Okay.
That adds it up to about 200. And so you're not as low as you could go as you have in the past. Yeah.
No, I was just trying to clarify the.
All right. Other questions? So based on that additional information, are folks comfortable moving forward today? All right, then can we have a motion?
I'll make a motion to approve the proposed budget as presented.
I'll second.
Okay, and on this one, I think we'll do roll call.
Okay, I'll take a roll call. Bill Emlin,
Yes?
John Jensen,
Yes.
Joshua Chadwick,
Yes.
Caesar Javaharian,
Yes.
Motion passes.
Just to let you know, the January is for the vice chair. It's 90 days prior to the end of the fiscal year. That's the budget, so February is great. Me too, so never mind.
All right, thank you. All right, then, we will go on to item C, which is the consider adopting an amendment to the Solano Emergency Management Services Cooperative compensate Solano County for costs. Basically, it's the franchise fee. So, Ben, we'll go ahead and...
Yeah, this is something that, like Bela just stated, that it's not in their contract, but, Medic Ambulances definitely helped us out in the years prior, and reviewing the budget and seeing where we were going to be short, we were able to come to an agreement, and starting April 1st, 2024, throughout the rest of the contract, May 1st, 2025. We're going to be implementing a $50,000 increase, which will bring us up to $650,000 for the franchise annual fee.
Okay. Questions have been on that? Okay. Do we have a motion on this?
I'll make a motion to approve.
I'll second.
Okay. All in favor?
Aye.
Aye.
And then she wanted to do
We want to do roll call on
that
this one, too? Okay. Sorry.
Bill Emlin,
Yes.
John Jensen,
Yes.
Joshua Chadwick,
Yes.
Caesar Javaharian.
Yes.
All right, then we'll move on to item D, which is the review and consider amendments to the Conflict of Interest Code. And I believe this code has not been amended for a number of years, so it's basically being brought up to kind of the modern legal structure for these. So is there a presentation from Julie on this?
Thank you. Yes, it looks like this was last done back in 1996. So we're way behind. It's supposed to be done every other year. So this is just bringing the code in line with the current statutory requirements and the board makeup.
All right, discussion on this one. Anybody have questions about that? If not, we'll take a motion.
I'll move it.
I'll second it. All in favor?
Aye.
Aye. Okay.
And then again, if she could do roll
Oh,
call.
we want to do a roll call on this one too, Julie? Okay, sorry.
Bill Emlin,
Yes.
John Jensen,
Yes.
Joshua Chadwick,
Yes.
Caesar Javaharian.
Yes.
And if I could, just one other issue on that before we leave. It's not to do with the vote, just as a reminder, this is right in line also with the Form 700s that are going to be coming out soon. Just keep an eye out for those, please.
Okay.
Thank you.
I was almost about to ask, on that form, does this change, does the updating this code change from what we did last year?
No.
Okay.
Okay. Okay, we are through regular calendar, and we're now down to board member comments. I have no further comments. Anybody have comments on the board? Okay. And with that, we will go ahead and adjourn and move on to our next meeting, which is, once again, when is it, Ben?
April 11th.
Okay. April 11th, yes.
All right.
All right, thank you, everybody.